So what I'm going to do, I'll just talk for a few minutes here on kind of my approach to ethmoid and maxillary surgery, and kind of give you some of my little tips that I have for doing these procedures. These are my disclosures. All right, so probably the first thing, important thing to know about surgery of the ethmoid and the maxillary is to understand the embryology of the ethmoid. And I like to think about the embryology specifically in terms of the basal lamellae of the lateral nasal wall. So if you think about it, the embryo has these little parallel plates of bone that are coming off of the lateral nasal wall. And it's those little parallel plates that are going to actually pneumatize over time that are actually going to become the structures of the sinuses there. So each one of those little plates contributes to an area in the sinuses. So the first basal lamella contributes to the uncinate and to the Agernazi region there. The second basal lamella, a little bit posterior, contributes to the ethmoid bulla. So again, thin plate of bone, slowly enlarging, filling up with air like a little rubber balloon in there. The third basal lamella is actually the true basal lamella of the middle turbinate. It actually maintains fairly commonly as a flat plate of bone, though occasionally also gets pneumatized. The fourth is the basal lamella, the superior turbinate, and the fifth, the supreme turbinate, if in fact there is one. So thinking about these little basal lamellae are very helpful as you march your way through your dissection of the ethmoid sinuses. And in fact, if you look for evidence of the basal lamella while you're doing your dissection, you'll see it. You'll see these little parallel flecks of bone coming off the lateral wall, the lamina, and that will help guide you in your dissection. Now, the second critical structure to understand is the middle turbinate itself, right? So the middle turbinate, it's a fascinating structure because it is oriented in three planes. It's oriented coronally, sagittally, and axially, depending on where you're located inside the nose. Coming anterior, from anterior to posterior, it's going to be in that sagittal plane. Then you're going to hit the basal lamella when it becomes coronally oriented. And then going beyond the basal lamella, posteriorly, it's going to be axial dimension, that horizontal portion of the basal lamella going back. Obviously, the middle turbinate divides the anterior and the posterior ethmoid sinuses, and it's that basal lamella which is the dividing point between the anterior and posterior ethmoid sinuses. And of course, occasionally it is nice and flat as a thin piece of bone right there, but very commonly it becomes somewhat corrugated in its appearance. And the reason for that is because you've got the little rubber balloon, the little balloon of the bulla, ethmoid bulla in the front, and it's expanding, it's growing, and it starts pushing back against the basal lamella. So it's squeezing that basal lamella and moving it posterior, but you've got the same forces, competing forces from the posterior ethmoid coming forward. And so it oftentimes creates this irregular or corrugated appearance to the basal lamella as a result. Now, the other thing you need to understand about the middle turbinate, and it's very, very helpful for doing surgery of the ethmoid, is that the middle turbinate is going to define the spaces or the recesses of the sinuses. And we're going to use those spaces and recesses to help us to do our dissection. I'll show you how I do that in just a second. It defines the hiatus semilunaris, the infundibulum, the sinus lateralis. All those structures are critical for our understanding of how to do the dissection. Now, this I'm showing you, I'm not going to be talking about sphenoid surgery, but I do want to show you the relationship here between the superior turbinate and the middle turbinate. This is really, for me in my practice, this is absolutely critical to doing sphenoid sinus surgery, understanding this relationship. So if you're, say you're a small ant, and you're walking through the sinus cavity from anterior to posterior, you're going to be walking into the anterior ethmoid sinus, the bulla, ethmoid bulla. You're going to burrow through the bulla and go into the basal lamella, right? Through the coronal basal lamella, and then you're going to enter the posterior ethmoid sinus, right? Now, the key thing to remember here is that once you're through the basal lamella and once you're in the posterior ethmoid sinus, you are not going to be seeing the middle turbinate anymore. Well, you will a little bit inferiorly, but that's not going to be important to us. When you look up medially, you're going to see the superior turbinate. Once you've gone through the basal lamella, you look up medially, you see the superior turbinate. That's tremendously helpful because the superior turbinate is your guide to take you straight to the sphenoid sinus. All right, so that's what I do when I'm looking for the sphenoid. When I'm doing my dissection, I go through the basal lamella, I identify the superior turbinate, and I go straight back then to the sphenoid using the superior turbinate. I can show you, we can talk about that more in the lab. All right, hiatus semilunaris. Hiatus semilunaris is a two-dimensional space. So think of the hiatus semilunaris as a doorway that's going to open into a room. All right, so there's actually, it turns out, two hiatus semilunari. There's a hiatus semilunaris inferior and there's a hiatus semilunaris superior. Inferior is the two-dimensional space. It's the doorway between the bulla and the uncinate process. Okay? Hiatus semilunaris inferior between the bulla and the uncinate process. It's crescent-shaped on sagittal view, right? If you have a sagittal cut head, you would see that hiatus semilunaris inferior between the bulla and the uncinate. It's going to be a sagittal, or it's going to be a crescent shape, following the curve of the uncinate process around the bulla. The hiatus semilunaris inferior, again, as a doorway, it's going to open into a room. And the room that it opens into is the ethmoidal infundibulum. Right? The three-dimensional space is the ethmoidal infundibulum. Hiatus semilunaris inferior, the yellow right there, opens into this ethmoidal infundibulum right there. Now, the hiatus semilunaris superior is the two-dimensional space between the bulla and the middle turbinate. Right? Again, the bulla is a discrete structure. It's a little balloon growing, filling up with air there in the middle meatus, anterior middle meatus, and it has a discrete back wall, superior wall, side medial wall. The lateral wall is going to be the lamina. Hiatus semilunaris superior is that doorway between the bulla and the middle turbinate. And specifically, when it was originally described, they were referring to the bulla and the basal lamella of the middle turbinate, behind the bulla, between the bulla and the basal lamella. All right? Sometimes that can be a potential space. That doesn't have to necessarily be an actual real space, because if the bulla is grown up real big and it's pushed back against the basal lamella, it might become contiguous with the basal lamella. But commonly, there is a little bit of space there, and I'll show you again how I use that in surgery. The hiatus semilunaris superior is what opens into the sinus lateralis. That's one of the spaces that we'll talk about here. Sinus lateralis. Okay, let's look at that. All right, let's talk about the nasal fontanelles. This is easy, right? Everyone's familiar with this. Remember that the covering over the medial wall of the maxillary sinus is essentially a soft tissue covering, right? So you have this, all soft tissue covering that medial wall, and then you have the uncinate process that kind of drapes down in that sickle shape over that. The uncinate process is what defines the position of the fontanelles. The fontanelles being a posterior superior space right here, or an anterior inferior right here, in front of the uncinate process, or in front and underneath it. And then classically, the importance here is to recognize that the natural ostium, the maxillary sinus, is typically located in the anterior fontanelle. It's not located in the posterior fontanelle. So this is one of my criticisms of balloon sinuplasty of the maxillary sinus, because typically what happens is you end up making a hole into the posterior fontanelle. And so you're making it in a location that's actually separate from the natural ostium, which could lead to recirculation and problems like that. So this is, let's see, can we run this video for me? This is an example. This is from my friend Brian Matthews over at Wake Forest. He had this nice video showing recirculation of the maxillary sinus. This is a right side, and he's using a little freer elevator to just displace the middle turbinate here. You're looking at the uncinate process steering at you, and then right here is a little bit of mucus getting caught up, right? You look in there and you see that mucus, and you wonder, why is that there? So Brian went ahead and did a canine fossa puncture then into the maxillary sinus, and he stuck his scope in, and look at this. See the mucus going there? It's going out through a hole there. It's coming in through a hole here. This is real recirculation. This is what happens when we don't encompass the natural ostium with the surgical ostium that we create in the maxillary sinus. Now, a lot of people can live long, happy, healthy lives with this. I understand that and I agree with that. I know that that's the case. But clearly, this can result in some problems for some patients with ongoing inflammation, recurrent sinusitis, things like that. So I really recommend trying to avoid this if possible. So Peter Wang said this one time, and I agree with this. Can you run this video also for me? The maxillary sinus, doing dissection of the maxillary sinus is the second hardest sinus after the frontal sinus, which sounds weird because it seems like it should be really straightforward. But I'm telling you, it's not. This is a 0-degree view. Now we're looking with a 45. This is a revision case, right? And I'm looking at this and I'm saying, wait a minute, this doesn't look right. And I'll emphasize here, one thing you got to do when you're doing your maxillary antrostomy, use an angled scope to look over and find that natural ostium. It's really, really critical. You're not going to see it with a 0-degree scope. So we're going to use a little probe. We're going to peel this down. This guy's uncinate process is scarred over where the previous antrostomy was done. He's getting a lot of recurrent maxillary sinusitis. And we're looking here, and we're going to peel down a little bit of that uncinate process there. So there, look at that. You see that? Right down here. I'll show it to you a little better in just a second here. I'm getting a suspicion that that's where the natural ostium is actually located, right there. Starting to just see a little glimpse of it there. We're going to peel that down. There it is, right there. And then we're going to go ahead and confirm that. We're going to go ahead and we'll debride just a little bit of that residual uncinate right there. And we're going to have to work that tissue. You can see how scarred it is right over the natural ostium there. Again, this is working all with a 45-degree endoscope. This isn't a 0-degree scope. So we're looking off to the side to see this. There it is again. You can start to see it. It's defining itself a little bit better there. But again, still scarred over and still separate from that surgical ostium behind it. So now we put our 90-degree forceps in there, cutting forceps, working through the natural ostium coming up now, and we're just going to divide that little band right there. And now our surgical ostium and our natural ostium are actually communicating. They're actually involved with one another. All right, so that's challenging. That's not something that you can just simply do with a 0-degree scope, just sort of randomly kind of grabbing over there. Really got to look for it. You got to think about where this is going to be and address it very accurately. All right, so let's talk about these spaces and these recesses. So again, if you recognize that the bulla is a very discrete structure sitting in the middle meatus, there's going to be space above the bulla, there's going to be space behind the bulla, there's going to be space medial to the bulla. All right? So the suprabullar recess is that space, or real or potential, that lives above the bulla, between the skull base and the bulla. The retrobullar recess is the space behind the bulla, between that basal lamella and the bulla. So the combination of the retrobullar and the suprabullar space is what we call the sinus lateralis. All right? Remember how we said that the hiatus semilunaris superior actually opens into the sinus lateralis. So the two-dimensional space between the bulla and the basal lamella opens into the retrobullar and suprabullar space. Okay? So the sinus lateralis, I got to say, first of all, it's an unfortunate name because it isn't a sinus, number one. It's a recess. It's a space. And number two is that it's not lateral. It's actually kind of medial and superior and posterior. So I'm not sure, you know, the original anatomist came up with the name. We got it. We got to use it, but it really is a little unfortunate because it doesn't really tell us really what it is. But the sinus lateralis is incredibly helpful to me as I do my sinus dissection, and this is how I use it in sinus surgery. I'm going to place a curette. I've taken the uncinate process off here. I'm going to place my curette into the hiatus semilunaris superior between the bulla and the middle turbinate, and then I'm going to push it kind of behind the bulla, and I'm feeling for that retrobullar recess. And then I'm going to, with my curette, I'm actually going to take the bulla down as a discrete structure. Not punching into the bulla kind of randomly with a suction or something like that. I'm actually going to use the curette and take the entire bulla off in just one fell swoop. Can we run this video for me, please? So here we are, again, looking at the left side. We call this the intact bulla technique. Placing that curette. See how we slide it back medial to the bulla, and then I'm feeling the basal lamella back there, and I'm starting to peel the bulla forward. Using my knowledge of the sinus lateralis and the retrobullar recess, and then similarly taking and reaching up, trying to pull the bulla down off of the skull base as well. Now, once we've got it all freed up there, now we can use our debrider and just clean it off very readily. But the point here is that we're doing this, we're understanding the anatomy, and we're respecting the anatomy, and we're using the anatomy to help us to do the dissection. So this is like a really fast, very thorough anterior ethmoidectomy, right? All right. So remember, as we can go back behind the bulla, going through the basal lamella, of course, the rule is always to stay low and inside, right? Because you don't want to get into the lamina, you don't want to get into the skull base. So you stay low and inside, you traverse that lamina, the basal lamella fairly low. And the point here, too, is that as you do your dissection, you don't want to miss out on cells that live down here, cells that live anteriorly up toward the frontal recess and Agernazi area. See, what happens is oftentimes we're really good with our 0-degree scopes and our straight instruments to head up into this gray area. And we call that middle ethmoidectomy dissection. But we oftentimes miss a lot of the tissue that's in the front here and down low here because that requires a little more dexterity. It's requiring angled scopes to get into that area. But you don't want to do that. That's an area where we see a lot of persistent residual disease. Similarly, we see the same thing in the coronal section. We see people doing a good job dissecting here medially along the middle turbinate, but leaving lots of stuff on the LaminaPappa along the skull base there. So that's our middle ethmoid dissection. We want to try to avoid that. All right. Finally, you know, it's important, as we talked about yesterday, you got to study your CT. You need to know that CT intimately before you start doing your dissection. That's going to give you a safe dissection. And again, we talked a little bit about Carroll's classification. I agree very much with what Ray said. I don't believe that that's so important. More important is the obliqueness of the cribriform and how it relates to the frontal bone above. And again, if it's more oblique, it's splayed out more along the skull base, it's going to be at greater risk of injury. So we look at that very carefully. We also look for asymmetry as well. And we see which side is going to be higher, which side is going to be lower. And remember, this is really basic, but again, you know, we see these complications coming in. You know, as your dissection moves posterior, you got to flatten out your instruments and flatten out your angle of approach, right? You know, because you can keep going. If you keep going straight up, I don't care if this is, you know, less than 7 centimeters. It's less than 7 centimeters into the frontal lobes. All right, so you got to flatten that angle out as you go posterior toward the sphenoid sinus, and always force your hand to be coming down lower and lower as you're heading posterior. Yeah. Again, look at that CT. Look at the integrity and the position of the LaminaPappa. You know, stuff like this, you see things like this, right? And this guy's set up for a problem here with getting into his orbit if you don't spend some time looking at that and recognizing that that LaminaPappa is very unusual. This is a great case right here because this patient actually came into me with a CSF leak over on the left side. So what had happened here, I know exactly what happened. I can look at the CT and I can see what happened with the surgeon who did this. They didn't appreciate the fact that there's essentially no ethmoid over here. The lamina papyracea is way over, medial, on this right side. They did their left dissection, it went fine. They came over to the right side, didn't appreciate the asymmetry. They follow lamina, good, but they blow right through the middle turbinate and actually blow right through the septum up high here because they were trying to create an ethmoid cavity that was just like they were seeing on the opposite side. But the point is there was no ethmoid cavity and they create a CSF leak up here as a result. So again, this to me is a simple thing that could be avoided if you just really sat and looked at your CT scan ahead of the operation. All right, so my philosophy is that FACS is not swizzle stick surgery, all right? I don't like to just sort of stick a suction into the ethmoid, wiggle it around a few times, and call it a day. I really believe that you need to think about sinus surgery and ethmoid surgery akin to middle ear or mastoid surgery. You don't do a mastoidectomy and leave a bunch of cells with disease behind. I don't think any of us would think that's appropriate treatment of a mastoid. And I also don't think that's an appropriate treatment of an ethmoid. I think we need to have that same philosophy as we approach ethmoid surgery. Clean lamina, clean skull base, no polyps, and of course post-op care and debridement are essential. So I think that, as Ray mentioned yesterday, I think our philosophy, our concepts have moved forward over the years, and we're evolving, right? It's not simply ventilation that we're trying to accomplish with ethmoidectomy. We're trying to debride the disease from the sinuses. That's what I would argue is a more appropriate concept. So we're not simply opening the OMC. We don't believe that disease is eradicated by simply opening it. You have to debride the involved sinuses, remove the inflamed underlying mucosa, mucus, and respect the adjacent structures. So this is a great example here, just a revision case, right, comes in. And again, the OMC and the sinuses have been reasonably dissected, right? But there's still a lot of residual disease left behind, a lot of osteotic bone, a lot of cells that have been allowed to persist there. And to me, this patient doesn't have a great opportunity to get better with all of that disease and inflamed tissue remaining there. So we're going to really focus on trying to complete that operation and be as perfect in our dissection as possible. All right. So complete thorough ethmoidectomy and antrostomy requires complete and thorough knowledge of the anatomy. Use your angled scopes. I think that's really helpful. Review your CT scan and avoid that temptation to simply believe that ventilation equals cure. As was pointed out yesterday, the concepts of the 1980s have evolved. We don't all have mullets nowadays, and that's a good thing. All right. Great. Thanks a lot.